All right. So let's get started. You know, as we talk with people about their fears and concerns, one issue that seems to be at the top of mind, pun intended, relates to our brain as we age. People often express fearfulness about getting dementia, specifically Alzheimer's. And unfortunately, however, few people are taking steps that have been shown to improve brain health and lessen the likelihood of cognitive impairment that accompanies aging. Today, our panelists are going to help us work through some of the questions we have about brain health. Keep in mind that the scientists are learning things every day. I'd like folks to come up just one at a time. Dr. Ho is an MD and a neuroscientist. Where would we be comfortable for you? Next, we'll introduce Kim Buttram. Kim has experience in gerontology, nursing, and helping folks that are helping families that are dealing with this disease too. And finally, a lady that I'm blaming this whole thing on, she helped me get all the right people, Lena Huang. She's Community Engagement Manager for the Alzheimer's Society. So were you able to get those things working? All right, here's the way to do this. I'm going to ask, starting with Dr. Ho, I'm going to be asking you just to introduce yourself, a little about your background, what you do, and we'll just start with you, and we'll get on the line.
Sure, thanks for inviting me. My name is Dr. Gil Ho, and I'm a geriatric cognitive neurologist. Basically, I'm a neurologist that deals with memory disorders and things that are related to that. And I trained at various places at UC Irvine, at UCSD, and I trained in the memory program there. And I run the PCND Neurology and the Center for Memory and Aging. And we have a location here in Carlsbad, as well as in Poway. And we also do significant clinical research. We're actually part of what's called the Alzheimer's Disease Cooperative Study, which is out of UCSD, which is quite a prestigious program. And so we have clinical trials that are available. So I do a little bit of everything, and I see patients too. I see general neurology patients as well. So.
All right, Kim.
I'm Kim Buttram, and I'm a gerontological nurse practitioner, and for the last 35 years have been working only with those living with either a memory impairing disease or some type of dementia. And Gil and I had to laugh because 25 years ago, we were both at UC San Diego. I was the lead nurse practitioner at their Alzheimer's Disease Diagnostic and Treatment Center, and then in Austin, became the lead nurse practitioner in the UT Southwestern Austin Memory Clinic in Austin. So yeah, this has been our specialty, and have been caring for people throughout the course of the disease. The last 10 years, I've actually been the Senior Vice President for Clinical Services at Silverado, which is a company that has 27 memory care communities in 8 states. And we have a specialized program for people living with all the way from mild cognitive impairment through to the end of life. And our Brain Healthy program, which is called Nexus, based on 5 brain health pillars, has been duplicated and internationally recognized for those living with early dementia. So happy to be here.
Great. Lena?
Hi everyone, my name is Lena. I'm one of the community engagement managers at the Alzheimer's Association here at our San Diego and Imperial chapter. I don't have extensive background like Dr. Ho and Kim here, but I have been at the association for 2 years now doing things like this, education and awareness for the community, for those who are wanting to learn more, have some connection to the disease, or again, just needing that support for their loved one or for their family member. I have a personal connection as well, so it has been very kind of full circle for me to be able to share these resources with the community and to educate as well. So thank you so much for having me.
Thank you for being here. So I've got a few questions I'm going to ask, and I'm going to just I'll use your name first, Kim, for my first question here. How does the brain change from the time we're in our 20s to the time someone reaches their 60s, 70s, and 80s beyond?
Ooh, you're sure you don't want to give that to the neurologist? All right.
To him in a minute.
Well,
I'll tell you what, Kim, give us your side of it, and then I'll let Dr. Ho fix it.
well, I would tell you that that it's very exciting what goes on in the brain, right? Because we know that for early in our life, it's growing. We know that somewhere midlife, it tends to get slower in some ways, but stronger in other ways. So, I think as we get older, and that's the exciting part, you'll be hearing more today about brain healthy activities that have really been shown to have benefits, but we should really be starting brain healthy activities much, much younger. And I'm sure Dr. Ho will agree with that, our teenagers and our 20-year-olds need to be worried about everything from modifiable risk factors. So things like high blood pressure, things like appropriate diet, inflammatory diet, and a variety of other things that I hope we get a further chance to discuss. So from my perspective, as an older person, I have now reached the geriatric stage that I cared for a long time. Good things happen in the brain, but there is some atrophy that can occur. But it's primarily, and I think, you correct me if I'm wrong, Dr. Ho, I would say it's that processing time and slowness that occurs normally. But the information is there, and often we compensate for it. Your turn, Dr. Ho.
Okay, thank you. No, she's right. That's important, and I'm going to leave the good news about all the healthy stuff to these guys, but I'm going to give you guys a reality check. So here's the reality check. So I tell my patients and their families about this all the time to try to put things in context, because they have trouble understanding why are they there and why do they have this problem, why are they in our clinic. And so in relation to this question, the brain changes over time. We know that. And she mentioned that it atrophies or shrinks, right? And that's due to a loss of nerve cells. But what's interesting is, and it's not entirely clear now to me, whether there is such a thing as normal. So she mentioned about processing time and those kind of things and remembering what you went into another room to get and then forgot what you were there for. As I always thought they were normal, but then now I'm actually revisiting that in my mind. Maybe a lot of these things are not normal. Why do I say that? It's because the brain actually accumulates things that we don't want. So if somebody is destined to develop Alzheimer's disease, for example, the brain will accumulate things like amyloid or tau or proteins and garbage, basically. It's the excess of what the brain doesn't need anymore, and it accumulates. And some of that stuff may be bad for the brain. That accumulation may actually start not when you're 60 or 70, but when you're 40. So actually, technically, if you think about the broader picture of time, because you have to include time in these definitions, if somebody has Alzheimer's disease, it probably didn't start when they entered the clinic. It probably didn't actually start when the symptoms came. It actually probably started from a biological perspective at age 40. And so that's why it's really important to do healthy brain stuff early as possible in midlife, because midlife is the precursor to what happens later. And you want to do it early rather than do it late. And so you want to try to prevent these things from accumulating as much as possible and preserve nerve cells as much as possible, especially in memory areas, especially in areas that you need, like memory, so that you can have resilience later in life. So if you do lose some, it's not going to affect you. The person that reaches the finish line with the most gold in the bank actually wins. And so the person that reaches the finish line with as many nerve cells as possible wins that race. So, make sense?
And that's actually why everybody sitting on this panel was excited when we were hearing about what the Senior Center is offering. We heard things like class in Italian and all sorts of things. And to Dr. Ho's point, that's what builds what is called cognitive reserve. right? You can continue to build and strengthen your brain and build that resiliency so that, to Dr. Ho's point, you start with a higher bulk, a bigger brain, a little is how you can understand it. And then if you lose some neurons, you're able to not demonstrate the symptoms of a dementia or a problem if you start bigger. And you can probably add to that, right?
Yeah, absolutely. That's one of the things we say to folks in our programs and families who call. The more you do now, it's never too late, right? As Dr. Ho mentioned, you want to start early, but it's never too late to start things like that, right? Learning a new language or knitting, right? What a wonderful thing to do, even here at the senior center. So that's some of the things that we always recommend folks to do is to find a hobby that you like, get out and do those things because it can only help in the long run.
All right,
And
Lena.
at least the benefit that's been seen is with something novel, right? So it's something new. So you don't have to keep doing the same Sudoku over and over. I can't do it, so I'm always impressed with anyone who can. But it's that new, as she mentioned, activity that you've not done before.
One thing we haven't talked about is, Lena, maybe you can help me explain to folks what's the difference between dementia and Alzheimer's?
Yes, my favorite graphic that we have from the association. So this is the probably number one question I get when I'm out in the community doing programs or health fairs or anything like that. Folks ask me like, what is the difference between Alzheimer's and dementia? Is there a difference? Can you explain that, right? And I really, really do love this graphic that we have from the association because it really shows that dementia is that umbrella term, right, for the changes in memory, thinking, and behavior. And Alzheimer's is a type of dementia. It is the most common. It accounts for about 60 to 80% of all cases, which is probably why folks hear about it, or maybe you even heard more and more in the news, especially now, which I'm sure we'll talk about in a little bit, some of the treatments that we have available. But yeah, so kind of think about dementia as that umbrella term, right? And then Alzheimer's being a type of dementia.
I think Dr. Ho should maybe explain the fact that one type of dementia that is really more present than often is recognized is a mixed dementia. And the piece that vascular disease in the brain has in terms of accelerating symptoms of dementia, and often there may be some vascular symptoms along with, or vascular presence, along with Alzheimer's changes in the brain. It's the brain's an interesting organ, right? It often has a variety of.
Indeed it is. So maybe to add to her point, Alzheimer's disease is not the only form of dementia. So dementia is really a term that describes somebody who is having problems thinking, because memory is a part of thinking. And that problem with thinking spills over into everyday life. Because if you can't remember the ATM pin, you can't go to the bank, right? You can't remember your account number. So it affects everything that we do in life. We take for granted, but everything that, thinking really affects every single aspect of our lives. So the types of dementia, Alzheimer's disease is not the only one. There are multiple. As she mentioned, there's a vascular dementia. When small strokes accumulate in the brain, then you can have similar kind of outcome. There are other things like Lewy body disease, frontotemporal dementia that are different than Alzheimer's disease, and that needs to be diagnosed, somebody that does this kind of thing. But there's actually been an interesting surprise in the last few years, maybe the last 5 years. There's actually been a new form discovered. I don't know if people have seen that piece on 60 Minutes. They did it twice, actually, a few years apart. Interviewed people up in Orange County in a place called Laguna Woods. So this thing is called TDP-43 encephalopathy, or LAT, limbic associated TDP-43 encephalopathy. Big long word. It looks exactly like Alzheimer's disease, and people above the age of 80 to 90s have more prevalence of this than they do have Alzheimer's disease. And oftentimes, the pathologies are mixed. You have some Alzheimer's disease and some TDP-43. Earlier, you can have Alzheimer's disease and vascular dementia, and they feed into each other. If you have a lot of strokes and you have vascular dementia, it feeds into the Alzheimer's disease and makes it worse. So you can have all kinds of combinations. I've never seen Lewy body and Alzheimer's disease, but I guess theoretically it's possible. So, yes.
Would you be able to define Lewy body?
Lewy body is a condition that looks very different than Alzheimer's disease. It's a much more aggressive condition where people have visual hallucinations. They see things that aren't there. They have trouble interpreting what they see. It doesn't look right. It's very confusing. And they have symptoms of Parkinson's. Not Parkinson's disease, often don't have a tremor, but they move slowly and they stoop and shuffle and have balance problems and fall a lot. And their symptoms go up and down like a roller coaster, the so-called fluctuations. And it's caused by something called alpha-synuclein, or people claim, because the Lewy body is something in the brain, and inside it contains this protein called alpha-synuclein. We don't know exactly how all these things fit together yet, but it's possible that alpha-synuclein or things like that are toxic, and they damage the cells that are necessary in the brain for movement and to ward off those symptoms. And so too much of it is probably not a good thing.
I'd like to
And
add-
just as,
Go ahead.
I was just gonna add, so from and that's the chemical, in the brain changes. I would say that many of you may know Parkinson's disease, right? And someone who has Parkinson's disease, it's not a firm, specific diagnosis because there's a whole lot of crossover. But in general, the diagnosis for dementia with Lewy bodies versus Parkinson's disease dementia, because people that have Parkinson's disease long enough may develop trouble with memory and thinking, it depends when the symptoms started. If you start with the motor symptoms, the stiffness, the tremor, and that kind of stuff, typically you will get the symptoms of Parkinson's disease and then a dementia. If you start with everything Dr. Ho described, the visual hallucinations, the fluctuations in terms of, and other issues, then you get the diagnosis of Lewy body dementia. But actually when pathologists, I think it's still true, when pathologists look in the brain, dementia with Lewy bodies and Parkinson's disease dementia look very similar.
Okay, fantastic. Okay, now I know this is the easy one. Are we able to self-detect our own cognitive deterioration? At what point are we aware of this deterioration or no longer realize that we are?
I'll go with this one because it's kind of interesting. So the majority of people that actually come to our center, the patients are unaware of their own memory issues. So they have a lack of insight into their own memory issues, which is why we need a visit partner. So for studies, we need a study partner. We need somebody who can observe externally what is going on because they have no idea. That's why you see many patients that develop any kind of dementing illness, such as Alzheimer's disease, that don't have anybody, that continue to deteriorate alone, and they get themselves into serious trouble. But they think they're okay. So it's kind of like it's a neglect, it's an unawareness of something. There's lots of different types of neglect, but this is a neglect of having a memory problem, which is very frequent.
I would
Very
kind of
common.
say you forget is an easy way to think of it from a lay standpoint, right?
And I would add too, that's one of the things we also stress with our programs is that most times the person doesn't realize that this is happening, right? They think it's normal, they don't think anything's wrong, and it's usually a family member or a loved one or someone close to them who starts seeing these things of they're putting things in random places, keys in the fridge, right? Or they can't remember things that interfere with their daily life. And so that's when we start to have that conversation about, let's talk about this, right? And I think that's maybe the scariest first step is to have that conversation. But if you're noticing something in someone, especially a loved one, and you're noticing that it's affecting their everyday living and affecting, how they operate, it might be a good thing to talk to someone about it.
And I would add in clinical practice, something we see a lot, and I know you must too when you're diagnosing, is that spouses especially, and children do this too, we all do, right, is you tend to think that what maybe someone did early in life when they just didn't want to hear what you were saying, or they didn't want to do what you told them to do, you know, so you'll hear, they'll say, I know she could remember if she tried harder. If I've heard that once, I've heard it, you know, many times in clinic, and I know Dr. Ho too, or, you know, because they seem fine, right? But they repeat something or say, and it's like, or they forgot, or you didn't tell me I have an appointment, and you get accused, you know, those kind of accusations. And so often it's hard for the caregiver too, to acknowledge that it's not within someone's ability to remember, that this is truly related to loss of neurons in the brain.
Yeah, absolutely. I was thinking about another point though. I remember seeing a poster or something from the Canadian Alzheimer's Association, and on the poster they made a point, if a family member brings somebody in, then you really should pay attention that there's something going on. If a person comes in and starts complaining about their memory, it's not that we discount it, but it may or may not be, you know, something significant. But if a family member brings a person in, you really got to pay attention, because there's something really, really wrong. It's not normal already.
So I get to watch a lot of baseball on TV, and they have these commercials with Prevagen. And I'm going to get me a bottle of Prevagen, and it's going to put you guys out of business. Is that true?
Fine.
Yeah, I get a lot of questions about that too, from all over the place. And certainly not to offend any manufacturers or you know whatever. But these things are actually supplements. They are considered medical foods. They are not FDA-approved medications, and they're not intended to treat or diagnose any condition, is what the official FDA label says. So they do not treat Alzheimer's disease. They do not prevent Alzheimer's disease. There is no data for that. Because the reverse would be true. If this were such a great thing, then you'd see it promoted. You'd see it promoted as an official medication for Alzheimer's disease, which is not. So you have to be really careful about things like this.
And many of those medications that are touted as treatment for Alzheimer's or for memory impairment, many times they have some kind of a supplement that has an Aricept type effect, right? Which means that it just kind of can maybe make someone feel a little more alert. But we would all say, save your money, right? Get in a walking program instead.
Those things are super expensive. I've heard this medication.
And the walking programs, nobody want to do.
You know, I will say, I always, when I was in my previous career, more explaining people when they had a new diagnosis of Alzheimer's, you know, I always described it as, think of it like a chronic disease. You know, for diabetes, we don't cure it, right? We manage symptoms and we work to delay progression. And if you end up with a diagnosis of something like mild cognitive impairment or mild dementia, the truth is you're going to do things that are going to try to manage symptoms. So if you have a misperception, if you have and although he's going to talk about the most recent treatment, I know, but in general, it would be managing symptoms like fixed false ideas, depression, other things that could occur. And then you're going to do things to work to delay progression.
Actually, I was going to ask you to tell us about normal mild cognitive impairment and then progression into dementia.
Well, you may have heard the term, right? And I'm with Dr. Ho on that whole thing about, and he'll describe some of the clinical trials he's doing, right, that have shown that you begin to see changes in the brain up to 20 years before for someone at risk for Alzheimer's. And, you know, we used to describe, like, mild cognitive impairment meant there was one difficulty in an area of thinking and no impact on functioning. That's still the formal diagnosis, but I think it's important to say it is much, much more fluid than that. The truth is, mild cognitive impairment, I would describe these days as very much the earliest stage of Alzheimer's disease. There are a few people that might have mild cognitive impairment who do not progress, but that has more to do with what was causing the mild cognitive impairment. If you have impairment of only memory and it's due to your sleep apnea, and you correct your sleep apnea, then yes, maybe it will not progress. But in general, I tend to think of it as the first symptom of a progressive neurodegenerative disease. Wouldn't you say that, Dr. Ho?
Yeah, absolutely. So she's right. It's a very fluid thing. So I unofficially coined a term that we like to use called the lifespan model. And I like that better because when you explain to people that this is not like, okay, there's a flag, okay, it goes up, okay, you have this, and then you have this, and you have, it's not like that. Because this is a continuum. It's a very gradual process. You may not even feel the transition from one to another, from being normal to having mild cognitive impairment to having a dementia syndrome of some kind. It's a very fluid, gradual process. And that's what people have to understand. You can give those kinds of designations, you know, in a clinical sense and, you know, based on criteria, but it's still very fluid.
And there are studies to show that some of the lifestyle modifiable factors that you can do earlier in that disease, if you end up with a loved one or yourself with a diagnosis of mild cognitive impairment, that's the time to take serious action if you have not in your 40s, as Dr. Ho already mentioned, to make sure your blood pressure is under control, to make sure that you are learning new things and continuing to build brain, to make sure you're reducing any other vascular risk factors, to make sure that your diet, you know, there's research on what's called the MIND diet or a Mediterranean type with less salt that has shown that people don't progress at the same rate. So there are things you can do, which is exciting. And the one thing that's not on that list is to buy Prevagen, right? It's a whole lot of other things we can do.
Right.
Add anything to that?
I got a strange question. Anybody can pick this up if you want. So I wake up in the morning and I'm feeling just a little groggy, right? And I can't remember where I put my keys, right? And I looked for my keys for a long time. Get in the car, drive away. 2 days later, come by again, and now I can't remember where I put my son. When do I know that I should start talking to at least my personal surgeon about things don't seem right?
Right at that point. That's exactly at that point. Earlier is better.
Help me
Okay.
me out with
So,
more examples or something.
So I'll tell you a little story. As an aside, I actually founded a nonprofit, but I don't do much with them. I check in with them every now and then, but it's the San Diego Dementia Consortium, and they have regular meetings. Actually, next meeting is tomorrow morning. They're in Escondido. Anyways, I was doing something for them, I was giving them a talk about a subject that really bothered me because I couldn't find people for clinical trials that were early enough in stage. And so I got my staff and, you know, I asked a local facility, can we go over there and, you know, just talk to people? Anybody who wants to be tested, we'll sit there all day and test people just, you know, for fun. And, you know, for their benefit, so they have some information about their own memory and thinking. Not a lot of people showed up, but, you know, maybe a dozen. And so this, which will go unnamed, is supposedly a normal senior facility. People that live there are supposed to be normal, right? That's what they told me. Okay. When we tested them, every single person was abnormal. Every single person.
And I would add to that because
earlier the better.
To his point, and this has, you know, Silverado is specialized memory care from MCI through the end of life, but I would say that research has been done in regular assisted living who are not in memory care, people that have not been identified, to exactly Dr. Ho's point. And 50% of the last study that I saw had noted mild dementia. You know, so if you're taking care of a loved one, you know, if you have problems with memory and thinking later than your question, you know, it's important that you get that treatment. And I guess from my perspective, I would want a doc like Dr. Ho to go in and have the discussion, because we still hear lots of stories of family members and people who have taken someone to a doctor and that's not been appreciated. They've been told things like it's normal. They've been told things like, or they've been told you have a problem with your memory, go home and get your issues in order, you know, And so seriously, a lot of in my experience, I won't be too judgmental, but a lot of doctors are not comfortable with understanding dementia and Alzheimer's disease as a chronic disease and making that diagnosis and letting them know what can you do at the earliest stages to Dr. Ho all the way through end of life. Was there a question?
Yeah, I'm over at ECSD, the Shiley Brain Study. I'm 81 years old. I'll try to speak louder.
I lose my keys, my eyeglasses, regularly I find them. What are the typical treatments that you would address these concerns with?
Can I just add something there, because I like yours. Go with the ones that have the side effects first, the drugs that have the side effects. And then,
The side effects, huge, gigantic list.
well, and I only know Dr. Ho from seeing him on TV. So, I guess what I'm asking is none of us have the background that you guys have, right? So when I see my mother doing something, what should we look for?
Let me reverse that
Okay.
question and answer the gentleman's
Can you
question.
just talk to me, just give some general.
Let me answer the gentleman's question real quick. So the reason why we want to emphasize early is not because we want to badger people, and there is no harm in actually going and checking it out, because if nothing's wrong, then hey, you're lucked out. And if something is wrong, you caught it early, because if you don't do it early, there are no good treatments late. If you wait 10 years, there's nothing you can do. And so the treatments that some of these things that you're asking about, we have symptom treatments right now for Alzheimer's disease. So if somebody's diagnosed with Alzheimer's disease and kind of used off-label for mild cognitive impairment, are things like Aricept, donepezil, Exelon, galantamine, memantine, right? Those are the four that we've had forever, since I was in training and even before that. So those are still around. They're still okay. They don't change anything that goes on inside the brain as far as the process in Alzheimer's disease. These are medications that are approved, FDA approved for Alzheimer's disease. They don't change what goes on inside the brain as far as the progression of Alzheimer's disease, but they do help the symptoms. It's a funny concept, this disconnection between the symptoms. You make the symptoms a little bit better, but you don't change what's going on in the disease, which has been a big problem in Alzheimer's disease research for decades, overcoming this disconnection between the two things. There are disease-modifying therapies. Should I?
You go ahead, please.
All right. I don't know if you had a question on that. Anyways, so there are disease-modifying therapies now. We didn't have it before, but the last couple of years, we've had 2 disease-modifying therapies approved. One is aducanumab, and the other is lecanemab, or Leqembi. Aducanumab is called Aduhelm. So these medications are monoclonal antibodies. They're antibodies that are directed toward amyloid. So you accumulate too much amyloid, it makes sense to want to take it out. And so these antibodies, so there's antibodies for everything. You look on TV and ads, most of those drugs are antibodies for skin and for Crohn's disease and for diabetes and for whatever. They're all monoclonal antibodies directed at a specific target. In this case, it's amyloid. So you take out the amyloid and supposedly, magically, you're supposed to be better, or at least not getting worse. It doesn't quite work that way, but aducanumab and lecanemab did show a slight improvement over placebo when taken for a certain period of time. But these are tricky drugs because these are infusional. And the other trick is that they can't be readily accessed. Well, at least aducanumab can't be readily accessed because there's some controversy about its cost effectiveness in terms of Medicare, in terms of others, and so it wasn't released to the public. It's approved, but you can't get it unless you're in a study of some kind. But lecanemab actually is released to the public. You can pay for it, it's quite expensive, and you have to go through the infusions. It's like initial series of like 26 infusions every 2 weeks apart with 4 separate MRIs. They are not benign drugs either because they can cause side effects, very significant side effects. The technical term is called ARIA-E and ARIA-H. And these terms really mean that the brain can H, hemorrhage or bleed, and E, edema, swell. So you can have swelling and bleeding inside the brain in a certain number of patients. It's around 15-ish% of patients that have this. And some can be really mild and not feel a thing, and some can be really severe and end up in the hospital. 2 patients actually did pass away in Clarity AD, the lecanemab, the pivotal study for lecanemab. 2 patients actually did pass away from this side effect. So, you know, it's a kind of an interesting choice. Do you want to be tied to an infusion pump every 2 weeks for an extended period of time? And beyond that, who knows? Because studies stop, and so you don't know what goes on. You know, should you continue it for the rest of your life? Don't know. And then you run these risks, and you have to get MRIs frequently to screen for these things. So that is what we have. We have 4 symptom medications and 2 disease-modifying therapies. There's lots of clinical trials out there of various things. There is another one coming behind lecanemab from Lilly, which is donanemab, which completed its Trailblazer-ALZ 2 study recently, because we participated in the Trailblazer-ALZ 2 study. So that data was submitted to the FDA, and it's expected that it will probably be approved as well. So there will be 3 now of these kinds of things. Again, another monoclonal antibody, a little bit different, but same thing.
I do want to add one comment to what Dr. Ho said about the importance of early. Why should you go early? And we actually did a study that was reported at Alzheimer's Disease International in Budapest and then again in Chicago with our Brain Healthy program, showing that people that entered early, so they needed an MMSE of 20 or above, and if they stayed in the program for a year's time, they had a 60% improvement compared to those that had no treatment in terms of the trajectory of decline. And that is all with modifiable lifestyle factors: exercise, cognitive training, a support group, stress reduction. And so I just want to reinforce that no matter whether it's pharmacological treatments, as Dr. Ho has said, if it's to reduce the amyloid burden in the brain, so hopefully you have no progression, that needs to be done pretty early too, as well as the modifiable lifestyle factors. You want to, it's important to get diagnosed early so you know what you're dealing with and you can choose it and get benefit, because the simplest way I know to understand it, correct me if you disagree, Dr. Ho, is, you know, you need neurons there. You need a certain amount of brain power there for these treatments to work. And if you're more progressed into the disease and you have more atrophy, there's less to work with, whether it's from a pharmacological standpoint or a non-pharmacological standpoint.
This is the apex of this whole thing. When we first started this year, we had one little seminar about diet and health, right? Exercise. I don't know about you guys. I don't want to be hooked up to a pump and taking MRIs. I think I'm going to continue going to LA Fitness every morning. It's not that hard. Think about the alternative when you're laying there in bed and saying, well, I'm just going to sleep for another hour, or I'm not going to work out today. Think about what Dr. Ho just shared with you. I don't want any part of that. I'm serious. I'll take care of my life. I'll go to LA Fitness. I'm there every morning. Stop by, say hi.
You know, it's a curious thing. I mean, the field actually thought this would be a big thing, and actually for the field it is, because for the last what, 50 years, there have been 200 and some attempts at trying to design a disease-modifying therapy for Alzheimer's disease, all of which have failed. 200 attempts. It's a very difficult problem. And it's not going to be the answer. It's not going to be the end-all, be-all, because it's only one small piece of everything. And to come back to this modifiable lifestyle issue, The World Health Organization has their top 10, like Letterman at Night, top 10 list, right? And there's a couple other things on that list that haven't been mentioned yet, which I found actually very interesting. And this paper was actually published in Lancet Neurology last year or the year before. And I looked at it very carefully because it's interesting. One of the things that they mention about that is really curious is hearing loss. If you have hearing loss and you don't treat it as a direct road to dementia, it's what they're saying, at least epidemiologically. And there actually was a big, so I attend AAIC, the Alzheimer's Association International Conference, at least virtually. I want to see what's going on. They had the session all morning just talking about this, hearing loss and dementia, and why that is. And I talked to a grad student at UCSD at the ADRC who has a research project on this, and we were talking about this, and why does it occur? What does hearing have to do with dementia? Makes no sense. But actually, some of those circuitry, the neurons that deal with hearing, also are affected in Alzheimer's disease, and so there is like an indirect connection between the two. And so this may be actually direct, but so did the hearing come first, or did the Alzheimer's disease come first, or vice versa? Nobody knows. But there is a connection between the two. So hearing loss must be corrected. The other thing that they said was that perhaps hearing loss and becoming socially isolated accelerates Alzheimer's disease, accelerates your dementia because you're not getting stimulation. You need stimulation, which is another thing. You can't be socially isolated. You need stimulation of your friends, your neighbors. That's why in Japan, communities, small communities, everybody knows everybody else. And everybody, these big group of friends, and they spend every day with each other. Socialization is really important. And the other thing is depression that was mentioned in this list, treating depression. But that goes with socialization, isolation, loneliness, and all those kinds of things. So get your hearing checked.
I would add blood pressure to that. I think,
That was
blood
there, too.
pressure is something that some providers that maybe aren't as up to date as Dr. Ho would mention, that if you're like 150 over 90, that's okay. There is now research to really show that pretty aggressive blood pressure. You want to speak to that, Dr. Ho? Because I think it was a Sprint study, right, that showed 100.
Yeah, I don't remember.
It was 130 over 80. You really need to strive for maybe less. So at least talk to your provider if your blood pressure is not in, 120 is good for the brain systolically.
Yep, I agree.
And so if you're running in that 140, 150, that would be something that most providers to focused on brain function would love to see it a little lower.
It's a vascular risk because high blood pressure leads to strokes, and strokes, at least small ones, bless you, small ones can lead to cognitive dysfunction, lead to brain dysfunction. And so they're all tied together. And then the cognitive, and then the vascular brain dysfunction contributes to Alzheimer's disease. So they're all tied together.
Yeah, and I think too, what you're hearing, right? I mean, I have no science background. I'm definitely not a doctor, but what you're hearing, right? I think looking at yourself holistically, looking at now it's hearing loss, like get your hearing checked, right? Make sure you're taking care of your blood pressure, getting out to LA Fitness every morning, right? And things that, again, you can do, every day, going out for walks. I mean, my parents are at that stage too, and they go out for walks every morning, and I say, all right, they're doing their part today, right? And so looking at yourself holistically and making sure you're taking care of that, I think is the number one thing. I think Dr. Ho mentioned the Lancet report. I think Kim, you too, about how some of these things that you can do now can reduce your risk of 40+% of developing the disease in the future.
And I know it's old now, but I always love to focus on the nun study. Are you all aware of the nun study that was done in the University of Kentucky? And very powerful information about the nun that they were convinced had no dementia because she was the most active and involved in everything. And they said, man, to live to her age would be great because she doesn't have any dementia. And when they did the pathology, the brain autopsy for her, her brain was filled with plaques and tangles, which speaks to purpose, which speaks to social connection, as Dr. Ho said, that when you have if you're sitting somewhere isolated and not out with people and not knowing that being alive matters and making a difference, that is also not good for your brain.
And let me point out that you're going to be listening to this at our next seminar, Your Forever Home. The idea, I've run into too many people that are living in the bottom floor of a 2-story house. Their family's gone, their friends are gone. You'll never make it to the machine. You're not going to get there. And this is why. We are not wired to be all alone in a corner watching TV. It's not going to work. And I'm sure you guys see it. I've been to a few of the communities around. I like Silverado the best. I'm not selling Silverado, but they understand that there is that other side of this, right? We all want a pill. Everybody wants a pill, right? Go to the doctor, get a pill, no matter whether you need it or not. This is going to be some time before that pill's ready. And like I said, when I first was exposed to Dr. Ho, he was talking about a new sort of system that he has. Can you just talk about that?
Yeah, so thanks. At our clinic, so I was trained through the UCSD memory program, and my mentor, Dr. Leon Thal, taught us a certain way to evaluate patients. It's kind of an esoteric skill. And so it was really great when you applied it in academia and research and whatever. It's harder to apply in the community. So I made some modifications so that we could apply it to the community. So when people come into the clinic and they get evaluated, everybody gets the same tests, everybody gets the same interview. You have to bring somebody with you. So a systematic approach to evaluation, it doesn't matter, I mean, it does matter if you don't speak English, but Spanish, German, French, I mean, those kind of languages are translatable as far as testing stuff, but if you speak Farsi or Malaysian or whatever, maybe harder. But nonetheless, we do our best and we try to test people, but we do ask the same questions about the same things, and so everybody gets the same outcome. A systematic approach is actually much more efficient to identifying individuals who have a problem, who don't have a problem, or who have mild cognitive impairment, those who need treatment, those who are interested in clinical trials, and who these people might be, and also impacts on the family, because these things aren't in isolation. They impact the family. It's never a person disease, it's a family disease, and so we have to deal with whole families too. We have to counsel whole families. And so I think our systematic approach actually works better. It's been reliable and consistent over 20 years. We've been doing this for 20 years, seen probably tens of thousands of patients already. The longest, and I follow them. Kim's point is, do I follow patients? Yes, I do. The longest patient I followed was out to 12 years. Saw them every single year, tested them every single year, have every single test score for every single year, which is what we did at UCSD, but now we do it in the community. And I think that's what you need to do, have a consistent system of evaluation, identification of diagnosis, and then follow-up. So I liken it to, I'm not a doctor, I'm basically a wilderness guide. People come to me because they can't get out of the wilderness. And then I show them the path out of the wilderness to get to the top of the mountain. That's the diagnosis. Everything is downhill from there because it's all care planning now. So it's all, what are we going to do with this information? How are we going to modify your life to make sure that you're safe, that you're well cared for, that you have stimulation, that you get the right medications to supplement that, but it's not all medications. And where do we make adjustments in your lifestyle or your life to make you more comfortable, more happy, and more productive? That's all it is. And so our systematic approach, I think, is really, really good for this kind of thing.
And if I could make a point, and I think you're right from one standpoint, but I always like to clarify, because there's sometimes a joke, and several, I think, said it at the front desk, like, memory care, no memory care. And you know, memory care has a huge stigma in terms of what memory care is. And I think it's important to really address that right up front, because for 27 years, Silverado has really worked to not be what people think of in terms of memory care. And I would say, you know, that unfortunately, memory care has a reputation for warehousing. Right? You're safe. You're bored. You're safe. In my clinical practice, I had many people say, I will never go to memory care. I don't want memory care. And you know, and I think it's important that if you're ever in a situation with a loved one or yourself, I would encourage you to stop. At least at Silverado, we are about educating others, come to one of the support groups, see what a brain healthy program is. Our residents have done more than, in 1 year, 8,000 volunteer hours outside of the community. You don't go behind Silverado doors and wait to die. You continue to live, but with the safety and security that's required from a memory impairing disease standpoint. So, you know, I'm always like to at least address the stigma that goes along with either a diagnosis. If, to Dr. Ho's point, this is a dementia diagnosis or an MCI diagnosis that you are going to live with for 20 years, then you need to be informed about what's available and what at each point in the disease are the best treatments available and the way you can make a difference and live the kind of life you want.
Oh my gosh, Kim, what you just said is like, for as many people as I get, you know, come by to our booths and our tables to ask questions, I get the same amount that do the I don't want to see, I don't need to know about this now comment. And, you know, I think too, it's really about being, you know, proactive and learning about it, right? I say, you know, the disease doesn't discriminate. If you have a brain, you know, you're susceptible, right? And so the more you know, the more to lower that stigma, the more education that you have for yourself, because you never know who you might, you know, come across that might need this information, whether it be yourself, whether it be your loved one, your neighbor, a friend. And I think to Kim's point, getting educated and going out and learning more is really the first step.
And you could probably quote the numbers. You know, many people say, I want to live to 100. Okay, so let's talk about the numbers that might have a dementia by the time they're 100, Dr. Ho.
So it goes up, there's a famous graph that my mentors Bob Katzman and Leon Thal always had, and every 5 years or whatever, you had an incremental number increase, and then the next 5 years you have another incremental increase, and so it's exponential. It's not like linear. It's like the number of people getting a diagnosis goes up like this steeply until you hit 80 or 90. Then most of everybody is already should be diagnosed, and if they're not diagnosed, then they have something that remains undiagnosed. I want to make a quickie correction to what I said. So being safe is not being bored. That is actually true. Yeah, we don't want anybody to be bored. We do want them to be safe though in our care planning, but we don't want them to, if somebody is prone to wandering, at some point we don't want them to wander out into the street. But we do want them to be active, productive, and have a meaningful life. Yeah.
Right before we move on to any questions, is there anything that these folks need to know before they start talking?
All your resources, everybody.
This is the woman to call for any kind of resources, and I would just say Silverado has often is happy to tour anyone. You don't even need appointments. You can just show up at Silverado Encinitas and see what's possible in memory care. So we love to be a part of the community too. And Dr. Ho's office, we've all got pamphlets outside to tell you about.
Actually, I'll hit you with one more lifestyle thing that just occurred to me, and it's head injury. You want to avoid hitting your head because head injury, head trauma can also contribute to cognitive impairment. And how do I know this? Because I'm not formally trained in traumatic brain injury, but I've educated myself in traumatic brain injury because I get to toot my horn a little bit. I actually am designated as the regional evaluator for the NFL concussion settlement for this region. And so I see them all, every single one of them. Which is a very strange experience because most people don't know them that intimately. but I know them all, every single one of them. And so you see things that are very interesting in terms of head injury. Avoiding head injury at all costs, and especially repeated head injury, is really important. So just be mindful what you're doing, because sometimes they're climbing a ladder to hang up Christmas lights or whatever, and then the overhang, and oh my gosh, that's not good. So now I'm really careful. I'll put on a helmet.
And I would add, Silverado was the first preferred provider that actually Dr. Pelham called when they needed to consider support for their players in the NFL. So to his point, the one thing you probably shouldn't do at age 60 is get on a bicycle without a helmet. And think about that repeated head injury, I think, even for our kids, right?
I put on a helmet religiously when I'm out riding my bike. And, I do want to say, too, I think one of the comments that we get from a lot of folks is that they feel so alone in this journey, whether it is themselves or with a loved one. And I can tell you, you're definitely 100% not alone. And so, as Kim said, we do have information outside. One of the things that I love to share with people is our 1-800 helpline. 24 hours a day, 7 days a week, you can call for anything, right? Like if you have a question, or if you're going through this journey with a loved one and you need to get them help or support, they'll be able to connect you with either a local chapter or local resources to share that information with you. I share a really quick story about one of the participants in a program that I had a couple months ago is living with his dad, who's living with the disease, and dad gets up, this is 2-3 a.m. and he wants to go home, right? But home is Pennsylvania, so he thought he could just open the door and walk home. So that wasn't going to happen. So, he called the helpline, and they were able to, give him, ways to get, dad back inside, back safe, back into bed, right? And so, that's one of the ways that this helpline can support. So, 1-800-272-3900. It's like engraved in there. But we do have rack cards and things outside with that number as well. Just wanted to share that.
Okay, now it's your turn. We'll go with questions.
Can you repeat that number?
Repeating the number.
Put it off so fast.
I know, it's like,
Here we go.
Yeah, so the 24/7 helpline for the association, 1-800-272-3900.
Thank you.
Go ahead.
Hey there, hi. Hey, with the hearing loss, concerned about getting them fixed when they're not working, or still working with them, wearing them all the time. Very uncomfortable. Different companies, you can work with to get them to fit, but you should wear them all the time. Just deal with it.
Yes.
Okay.
People hate.
Just deal with it.
People can't stand me. I'm always harping about this thing every single day.
But it's so
15 times a day. But yes, it's difficult.
Yeah.
You lose them, batteries run out, doesn't fit right, not comfortable.
Is it worth?
You gotta look around and find something that works for you.
Is it worth? Sorry, people. Is it worth trying different ones, different times?
Yes. There are different ones. There are different ones that
Switching
fit better.
out them different days, to have two different kind.
Well, you have to find one that's comfortable for you. I mean, if you get two and they're not, both of them aren't comfortable, then you're going to be miserable all the time.
So you guys all got the brain? Oh, great. Here.
Thank you. We've talked about lifestyle changes, and I think it's coming up in another presentation, but could you speak about them a little bit more and how that facilitates the slow progression?
Well, I'll start, and I'm sure Dr. Ho, they can correct me if I'm wrong. But in general, what's been shown is learn how to use a mic would help. All right, so learning something novel. So throughout life, every time you learn something, and don't just do the repeated, even things like if you're walking in a different area, and all of those things are novel to your brain. And if your brain has to figure out something in a different way, that's important. That actually is, at least from the research that we've last seen, is that it tends to build neuron. So taking up piano, if you never took up piano before, I'm not a piano person, but for sure I try, although you have to be careful and make sure you're not gonna lose your car, so have it as a backup, that your phone can find it, but park in a different place, or, those little things that make a difference. You cannot stress long enough that the amount of physical exercise that's needed is not huge. People have in their mind, do I have to become a marathon runner? No, you do not. In fact, the most current research even says small bouts. You can do 10 minutes 3 times a day. But so far, the evidence that's for brain function that's shown the improvement is 150 minutes of moderate exercise weekly. So if you think about that, that's like 30 minutes a day. But, 30 minutes, 5 days, let's subtract correctly, multiply correctly. But the point, I figure you can take Saturday and Sunday off. But that doesn't have to be all at once. Many of us can't do 30 minutes all at once in a walk. But 10 minutes walk to all the things are really, really good. So that's good for your brain, and that's the evidence in that regard. In terms of purpose and connection, there's some evidence. There's even evidence for those of you that may still be working. Stress is not good for your brain. I had a neurologist describe it to me once, that cortisol, that if you're chronically under cortisol, at least animal studies, which is produced when you're stressed, that shrinks the brain too. So, if you have your phone with your Calm app, or if you want to take, meditation or yoga, we do yoga at the beach in our Silverado Encinitas community. They go to Doheny Beach for stress reduction. So all of those things are shown to be beneficial. The thing I would worry about most at home is that ability to become isolated and sedentary. Those are 2 brain killers, and so you really want to think about getting out there, feeling like you're making it, where you can volunteer, where you can make a difference. Want to add anything to that?
And I think some of the things too that you think about every day, right? Sleep is a big one, getting enough sleep. Granted, I also have to work on that.
Totally forgot sleep. That is like one of the most important things ever. And if you have sleep apnea, getting it corrected is important.
And then things Dr. Ho and Kim have talked about, right? Eating right. Looking at and, taking account of what you're putting in your body, right? We all love our chips. I love chips, but maybe not every day, every meal, right? And watching what you're putting into your body, and making sure what you're putting in is good for you. And I think coming from what we've all kind of talked about this past hour is looking at your whole body and taking care of your whole body. Therein lies taking care of your brain, right? What we say in our programs all the time: what's good for your heart, what's good for your body, it's good for your brain.
Yep.
Everything these guys are telling you is in a great book. It's called Outlive. It's by a guy named Peter Otto, and he stresses exercise, diet. He goes through how we're all different, and I'll tell you that's because our metabolisms are different. So you're going to have to get involved in your health. I mean, other than saying, "Oh, I wish I felt better." No, you're going to have to actually go to work. Because here's the way that I look at this. The last thing I want to be is in my early 80s, not knowing where I am and sick as a dog most of the time, but I'm still alive. I don't want to be that person. I want to be the person that in his late 80s or in his 90s gets sick and 3 days later is dead. That's my goal. But it is everything that they're telling you, you can't argue with. Nobody likes to exercise. Nobody wants to give up potato chips. Nobody wants to give up beer. Well, and everybody wants to live to 100. No, that doesn't work. You may live to 100, but you're not going to like it. Any other questions? Yes.
And wait a minute, keep in mind, you're sitting in a senior center right now, so a lot of those things that you may not know how to do, we're gonna go here first. There's a catalog, and there's people in this room. Talk to them. Meet a new person. That's good for the brain, right?
What's Peter's last name?
I'm sorry, my hearing aids aren't working too well.
The book.
Outlive. It's called Outlive.
And the author is,
Peter Atta.
can you spell that?
P-E-T-E-R. A-T-T-I-A, I believe.
Okay, I'm dyslexic, can you spell a little slower?
Okay. Atta. A-T-T-I-A. I'm telling you guys, I mean, you're gonna look at your doctor a little bit differently, and you're gonna look at yourself a little bit differently when you finish that book. Because you have to get involved in your health.
Actually, it reminds me of something else. I don't know if you've heard, there's another thing about longevity, and occasionally it gets talked about in the media, but there's this concept of places that have people that outlive other people healthily, so-called blue zones. And it's a little, I mean, it can be controversial, and but in general, I think the principle is sound. I mean, these places have certain characteristics. They live a certain lifestyle. Like for example, people in Okinawa, they live to phenomenal age. And you see these 80 and 90-year-old ladies hauling the tools, hand tools, out to the field. And they're sowing their seeds, they're plowing the ground, and then they're harvesting their crops. And then they bring a big basket of stuff. And they have to walk because there's no transportation. So they have to walk from the field back to the house, carrying all this stuff. And they do it every single day.
And if you're in Southern California and you're not gonna take the tools, Loma Linda's a blue zone, right? But they walk everywhere and they're vegetarians. So you can modify the best practices that have been identified in blue zones to make yourself healthy.
These blue zones, you can find it on Netflix. It's a documentary on Netflix, but it is amazing to watch one guy in Mexico who they went to interview and they couldn't find him. And finally this guy comes by riding a horse, right? And they said, that's him. And this guy was in his late 80s and he was still working 6 hours a day hard as a cowboy. I mean, and when he was talking to the interviewer, you would have thought that maybe the guy's in his early 70s or late 60s. Just to reiterate.
I have to laugh,
Don't mess
I'm gonna share because I don't know if everybody in this room, but I had one resident tell me she was involved in our Nexus programming and they were doing exercises that day. And she said to me, honey, I used to pay people to work this hard. I don't want to exercise at this point in my life. And so I would just say, think about the exercise that's fun. Think about those 10-minute bursts that you can do if you're not at the level that we're talking about is needed.
Alcohol.
Alcohol.
Avoid it.
I have a feeling.
Avoid it completely.
Maybe it.
What's the answer?
No, he just said
I would avoid it completely.
The research is not that strong, and many of you may have heard that earlier research, like resveratrol, you should take the pills and you should have this much wine in a day. Most of the evidence really is that if you're not, there's no reason to have it. It is not a brain healthy habit, it kind of is neutral. Would you say this?
Yeah, I mean, if you want the antioxidants and the resveratrol, go get some grape juice. Literally, I mean, it's the same thing, it's just fermented, I mean, it's the same thing.
I know you were hoping that they would say, just keep it down to 1 bottle of red wine a day or something.
Nice, yeah.
I'll get those, I'll find those guys, bring them in here next
Keep
time.
it down to the last.
Yeah, is there a genetic factor to Alzheimer's? I know that with Huntington's disease there is.
Yeah, I knew this would come up sooner or later. So genetics for community, sporadic Alzheimer's disease, for the stuff that we see in the community is less clear. It's multifactorial, and there's this thing called ApoE, which is a risk factor, but it doesn't determine whether you're gonna get Alzheimer's disease. But I've seen these people go to these commercial outfits to get genetic testing and get their ApoE done when they're like 26 years of age. Bad idea. But what if you do have the risk factor, the variant? You're going to think about that for the rest of your 50 years, right? It's kind of a pointless thing to do.
We can't say how important that is, that it is an age, and the ApoE4 is actually an age determinant of when you would develop Alzheimer's. It is not an absolute, so hear what he says.
Absolutely, yeah. And so for a small number of people in this world, they actually do have a determinant gene. Which is a mutation in amyloid precursor, makes amyloid, in something called presenilin 1 or presenilin 2. Those three are the big ones. There are some other smaller ones, but those are the three big ones. So I'll give you an example of that. There's a well-known example about a group of people in Colombia, that are outside the town of Medellin. So it's famous for a lot of things, probably not so great, but it actually is famous for this family. It's an extended family of like 27 generations. And there was a single individual from Portugal who was a conquistador, landed there, intermixed with the people, passed on this particular gene mutation in presenilin-1, which is technically it's the E280A, so-called Paisa mutation. Every single generation from there on passes this mutation down. And more than half, probably a lot more than half, of each generation develops Alzheimer's disease early, like at age 30, 40. And so these guys are like, hey, sign me up for the study. And so they're flying back and forth from Colombia to Arizona to Savannah, and back and forth and getting spinal taps and getting scans and whatever. Hey, sign me up, because if you can find something to help me, you can help everybody, but you can help me. Because we have no hope, because it's a genetic condition. It's a determinate condition. Every single generation is going to have it. That's the exception. That's not everybody else. For everybody else, it's not so clear. ApoE, the 4, you have a 1, 4, or 2, 4 allele of ApoE, then your risk is higher. But it doesn't mean you're going to get it. It just means that the risk is higher. And it probably intermixes in with everything else that we've talked about to determine what that final outcome is going to be.
And going back to the book, that is in the book. Outlive.
Oh, go ahead. I have it. So I don't drink alcohol, but I am a sugarholic. I need my sugar. Is that like super bad? Yeah.
Yeah, you know, I swore off of soda.
I don't do soda.
Haven't touched the thing in like
Candy corn is like fun.
Yeah, I literally haven't touched the thing in like 20 years because soda is terrible. Because this soda has this much sugar. Actually, the bag of sugar is this big. And the thing about it is, it's a major thing for, you can have a dessert every now and then, that's not the problem. The problem is when you're drinking this soda every single day, then you develop diabetes, and diabetes is a risk factor for Alzheimer's disease. It's a very well-known risk factor for Alzheimer's disease, diabetes. In fact, it's so much a risk factor that some people have claimed that Alzheimer's disease is type 3 diabetes, which is a controversial term, and I'm not going to defend it or whatever, but it drives the point home that diabetes is important to avoid or to treat if identified.
And as another sugarholic, I would simply say the moderation is the key. Even the MIND diet, which has been shown to prevent neurodegenerative delay, allows for an occasional, as Dr. Ho said, sweet. It's the everyday lots of them that's the problem.
Yes, I have a question. Is there an association between white matter disease and dementia?
Yeah, so what is this white matter disease thing? So nobody actually saw white matter disease until there was imaging or until somebody passed away and a pathologist was able to look at the brain, because you can't see it from just looking at somebody. White matter disease is the thing that you see when you scan somebody's head with MRI or CT that is in the center of the brain, because your thinking nerve cells are on the outside, and then there's these wires. The wires all have insulation called myelin, and that looks white when you section the brain. And so you see this on MRI as white matter disease when you see the little small spots that show up on an MRI. Yes, the larger the burden of this stuff, the higher the risk of cognitive impairment and dementia. So there probably is some threshold of how much of this stuff one can scan. But this is so common. It's like, I don't know, 9 out of 10 scans that we see of people over a certain age, you can see this stuff on the MRI to a certain degree. So it's really, really common.
And have they shown any ways to reduce that amount?
Probably reducing vascular risk, not smoking and, treating diabetes, blood pressure, cholesterol, those kind of things are probably still the best things to do. Taking an aspirin, if somebody tells you to take an aspirin, that kind of thing.
Okay,
Okay, you talked about sugar, and I heard recently that drinking diet sodas can lead to Alzheimer's. Is there any evidence, research to back that up, or is that just a?
I mean, I don't think, I have not seen a research study that has said that that sugar, so artificial sweeteners lead to Alzheimer's. I will say I've seen some small studies that have shown that if you're drinking like diet sodas all day with a lot, I think it ended up being like 15 cans or something of a diet soda, that it did increase your risk of like diabetes. Like it's not as, you know, and so it's not, again, I would just encourage everyone for moderation. I know of no studies particular to artificial sweeteners.
Right. I haven't seen anything like that either, but that's something that we hear too, right? And I think, to Kim's point, moderation, but also be wary of what you hear out in the world, right? Not saying that, you know, what we're saying is all true, but, you know, we're looking at studies and looking at things. I mean, Dr. Ho's practicing, right? And so, you know, just be wary of what you hear. You know, look at what studies are out there if you're, you know, study buff and you don't want to find things like that, because, you know, there's something about something out there, right? And so, you know, really educating yourself really will help.
And I'm gonna add, Google Scholar, feel free, you know, Google, Facebook, social media, it says so much misinformation because Alzheimer's is very feared in a lot of people. I would encourage you, get on like Google Scholar and really start looking at where's the evidence and are there truly randomized controlled trials, because Dr. Ho was mentioning there's a lot of no evidence for claims people make.
I have a question. I work with a lot of elder seniors, and some of them I go take them to their medical appointments, and we just did a dementia test. What is the purpose and how, this is for me, just so for my knowledge, what is the purpose when they have these tests, and then we have it, say, a year or two later and keep track of it? What can we do with that information once we get it?
Yeah.
I'm gonna add something before Dr. Ho answers because it's his question, but when I was in clinical practice, we often used a MOCA, which is a difficult test, and has questions of executive function. And, you know, executive function is that ability to not be scammed, to have appropriate insight and judgment. And I would say for someone who's anyone has a concern about, I'm sure Dr. Ho does more neuropsych testing, but some of these screening tests that are a little more complex one, can help family members know, is this someone who should be living alone? Is this one who should have a cell phone? Is this someone who should have a laptop? Are they at risk for fraud and things like that? Go ahead.
Well, she is at risk for
I mean, absolutely. So the purpose for doing that, for tracking people, is several-fold, is to know where in the continuum they are. How severe are they? And what I hate that word stage, but stage, that you need to do certain things or be aware of certain things. So one example is driving, because driving has criteria based on some of these scores. Also, participation in clinical trial also is based on some of these things. If you want to participate in a clinical trial, you have to be a certain score. So yeah, there's many reasons to do this kind of tracking.
And you know, especially in Alzheimer's disease and dementia, and that's because this is a disease that social skills remain intact until late in the disease. So if you're not formally tested, you're not going to pick up that they're having problems.
We're running out of time, folks. One last, anyone? Okay. We're going to end the questioning. Okay, one last question. Here you go.
One last question, I got one.
Okay, so, and this is gonna be hard to change, but, so like the sugar and the alcohol and stuff, I'm going to die. So, what's the best sugar not to have sugar? Like the pink sugar, the blue sugar, and the coffee in the morning? Okay, no more soda, that's gonna kill me, but I'll survive. But I need my sugar in the morning in my coffee. And sugar, I love licorice, and I eat it like I shouldn't.
So moderation, having a sugar is okay. Having sugar all day long is not good, right? You have your one, but you know.
And there's no evidence for one of the artificial sweeteners over another.
Right, there's no evidence for that. So I'll give a really quick plug. So right now, for the Alzheimer's Disease Cooperative Study, we are running something called the Viva Mind Trial, and you may see brochures out there. So we're looking for individuals that have concerns about their memory, or their family members have concerns about their memory, even as early as possible. Early the better, if they're interested in this thing. So really short. So the Viva Mind trial is looking at, it's actually an FDA fast track program. And if you don't know what the Alzheimer's Disease Cooperative Study is, it's a private-public partnership that's partially funded by the government in order to identify novel therapies, things that people wouldn't normally look at. This thing has been fast-tracked because it looks at a very specific subset of amyloid. It's called pyroglu A-beta, it's modified A-beta, which is like quadruply toxic to the brain. And targeting this specifically, using an enzyme to prevent this modification from occurring. It's an oral medication, which is different than being hooked to a machine. And so we are testing this thing nationwide, and it's also being run in Europe in parallel. And so as early as possible. And our study site is in our Poway location. But we're looking for as many people as possible that are interested to screen for this thing. You can have a memory issue without a diagnosis, come over, we'll take a look. They'll do some stuff, do some tests, and then we'll figure out if you qualify or not. But please consider this, because it's really important. Because we want to meet our goals and make sure that we have information. Sure, everything's outside. You know, the study brochures, study materials are outside. If you have any questions about it, let me know.
You can get some of this information on the internet. Dr. Ho did an interview on one of the early morning show programs, and they have a real good outline of this thing. I mean, this thing looks like
And they're the website, so you can find everything on the website. It's vivamind.org or something like that.
So can we give our panelists a hand?